I'd like to invite Dr. Vijay Kumar Mahala, Senior Consultant Interventional Cardiologist at Narayan Hridayalaya from Bengaluru for the next 12 minutes. Ladies and gentlemen, this will follow with a 12-minute chairman's comments and questions from the floor. Dr. Mahala, please.
Good morning, chairpersons, ladies and gentlemen. First question is secondary prevention required after CABG? We have a patient who has total arterial complete revascularization. Still we need therapy? The answer is yes. Why? The patency of the grafts decides the outcome. To have the patency or not to have the patency, if we do not have the patency, we require re-intervention in terms of angioplasty or redo surgery. We know the angioplasty in a graft patient is different from the native vessels, and we know the redo CABG, the outcome. Therefore, secondary prevention is required even after bypass surgery. Many patients, when they come to us for surgery, the first thing is aspirin is off because they think post-op bleeding is higher. I wanted to make it very clear, the aspirin has to be continued pre-operatively and to be started within 6 hours of surgery to have the patency of the grafts. So please do not stop aspirin even though patient is going for bypass surgery. Next, very simple, this is the focused update which was published a couple of months back. The patients going for bypass surgery, divide them into 3 groups. On my right side is called stable ischemic heart disease. Stable patient has gone for surgery. The middle, recent ACS has gone for surgery, and recent intervention has gone for surgery. These are the 3 category of patients. If you look the antiplatelets, it should be dual, DAPT. Whether it is a class 2B or a class 1 indication, but for us to remember, it is double antiplatelets. When I am talking of DAPT, I am talking the second one of DAPT, that is clopidogrel. What about aspirin? In our country, we have 75, 100, 150. Earlier, nobody was sure how much aspirin to be used. But in this focused update, it has been clearly mentioned, if you are using DAPT, the aspirin dose should be 75 to 100. Make it clear. The aspirin is 75 to 100. In the first category, stable ischemic heart disease or ACS, it is the second drug is clopidogrel. Whereas, if the patient has an PCI, the recommendation of the DAPT is as per the PCI. How long? The question is asked, I have a bypass surgery, I am doing fine. In addition to aspirin, you have increased another one clopidogrel. It's how long? I am doing fine. But the recommendation is beyond 1 year. Still you can continue, which is a class 2B. Meaning is, if the patient does not have bleed related to DAPT, the patient does not have bleeding diathesis, or patient does not require oral anticoagulants in future or during course of the disease, it is not required to stop it. You continue it. What about VK antagonist or non-VK oral anticoagulants? Is there any role to protect the grafts? The answer is no, big no. To have the patency of the graft to start this, no, unless there is a pressing indication to start it. Then about the lipids. As we have discussing for last 2 days, the lipids should be high intensity or moderate intensity as per the recommendation. But CABG belongs to the high risk category. If less than 75 years, the intensity of the statin is high. More than 75 years, start with high intensity. If do not tolerate, moderate. Is there any class 3? Class 3, if you do not continue statin, it is a class 3. There is a harm. So you should continue statin pre-op. You should continue statin post-op. And that is what is the recommendation. The contraindication of class 3 is only intolerant to statins. About this trial which was published a few days back in European Congress of Cardiology, this is just a 6,000 patients studied to find out how many of us, the patients are sticking to the 2013 statin guideline of SCCHA. Not surprising. only 74% of the eligible patients are receiving statin, out of which 45% only receiving the statin recommended by the guideline. So that means, is it the patient underutilizing or the physician is underutilizing? Next is 2016 SEC revision, because 13 guidelines said only statin, no non-statin. If you are not able to control the LDL with the statin, what next? Each non-statin came, which is ezetimibe as the second line, which is the protocol like familiar hypercholesterolemia. If it is not controlled with the ezetimibe, the third line comes either PCSK9 inhibitors or other drugs. Mind it, in our country, lot of prescriptions goes with the fenofibrate because it is easily available. To note, fenofibrate has shown numerical reduction in the lipid level, especially triglyceride. It has not translated into cardiovascular benefit. Beta blocker. In non-cardiac surgery, yes, there is some controversy of beta blocker. But patients going for bypass surgery, beta blocker has to be prescribed preoperatively to prevent post-op atrial fibrillation unless contraindicated. Beta blocker should be given to the patients who had MI or LV dysfunction. And beta blocker, as we know, in the heart failure, bisoprolol, carvedilol, metoprolol. The usual practice is patients with ischemic heart disease invariably goes with metoprolol. But mind it, if it is heart failure, it should be different. About hypertension. What is is it different in CABG? We have JNC8, sprint trial, different cutoff. But in CABG, the cutoff is less than 140/85. However, this has not been established in the trials, but is a guideline. Remember again, in JNC8, in a origin hypertension, it is the ACD. ACE inhibitor, calcium channel blocker, diuretics or diuretics CA. However, in hypertension with the CABG is the beta blocker. Next comes the ACE inhibitor after you realize the kidney function is stable after surgery. Third comes the calcium channel blocker or diuretics. It is somehow different in hypertension after CABG. Routine recommendation of ACE inhibitor if the patient does not have CKD, diabetes, MI or LV dysfunction is a class 3. MI. Even after bypass surgery, these are the category of patients called repeated returners. They return to the hospital to occupy a bed in the CCU because of the heart failure. We think patient has undergone bypass surgery, do not require medicines, we stop it. Remember, it is, if you discontinue the medicines, those who have MI or heart failure pre-surgery, they continue to be in heart failure. So these recommendations are as usual for heart failure, beta blocker, ACE inhibitors, aldosterone antagonist, and one point here about the ICD. The recommendation of the ICD post-MI, we take ejection fraction less than 35% for a window of 40 days. After that, we put an ICD. Whereas in CABG, the window is 90 days. We wait for a little longer time for the ejection fraction to stabilize. If it is not, ICD should be implanted. Diabetes, as usual, 7. But here, we are not very tight because the patients are post-op, they go into hypoglycemia repeatedly. It is better to be little labile rather than very strict. Smoking is very easy. Ask them to quit, not to stop. Quit it. It should be started in the hospital. We start them rehabilitating as early as they become ambulatory. And if they require supplementation of nicotine replacement, it should be done usually after discharge. Obesity, just now discussed. In Indians, if you look, all of us sitting here, the BMI is not high. BMI is very acceptable range. It is the waist circumference which is higher. So even after bypass surgery, one has to look at the waist circumference to keep it under control. Like we wanted our females to be much more healthier, having a cut-off line of 35 inch. Whereas males, we are allowed little to have an obesity in terms of 40 inch. Cardiac rehabilitation, it has been discussed and it is one of the mainstay. This is another area. After bypass surgery, the patient undergoes rehabilitation because he has not forgotten the pain of surgery. But after 2 months, he is free. I don't want any other exercise. This is a trial which is published again, European Congress few days back. If we extend the rehabilitation, of course this trial is for STEMI patients, extrapolating to bypass patients. If we extend the rehabilitation even 1 year, they definitely derive benefit. About the vitamins, previous speaker spoke about, unless there is a deficiency, because the patients ask, oh, I am tired, can you prescribe one vitamin? It is usually not required unless there is a deficiency. Of course, omega-3 fatty acid, which is available with us, the international brand, the cost is 75 or 80 rupees the omega, and you have to take twice daily. Even though you have a baseline good diet, it will supplement. Mental health. This is very, very important area after bypass surgery. The patient's husband, wife, elderly, sitting in front of you on OPD, wife complains. Husband forgets everything after surgery. He's very irritable. He doesn't know where his peg. And the husband whispers, why not I am forgetting you? I am able to remember your name. So the wife says, it's better you forget me. Because if you forget me, you will not be knowing whether I am working for you or not. So this is in a lighter sense, and that's quite natural. Because of the impairment of the cognitive function in the outpatient, that the patient is forgetting. And this is more often when the patient has been operated on pump. And they have studies of showing that repeated embolization, infarction, silent brain injury can add to this agony. They should be evaluated if required by a psychologist or a psychiatrist. Then vaccines. We forget this. This is, everybody has to remember, it has become a class 1 indication. Even after bypass surgery, the patients are not immune to get repeated respiratory infection, post-intubation status, lungs, comorbidities, and they are all elderly population. So to vaccinate annual once or 0.5 ml deep subcutaneous or intramuscular will protect them against respiratory infection. So before I conclude, secondary prevention is essential after CABG. Why? To maintain the patency of the grafts and not to allow the patient to undergo repeated trauma of revascularization in terms of PCI or redo CABG. Thank you very much for your kind attention.
Thank you very much, Dr. Mahala. Please have your seat. We'll have 10 minutes of the chairman's comments and questions from the floor. Over to the chairman, Dr. Chopra.
So we have 5 minutes to discuss.
We've got about 7 minutes.
10 minutes. So I think this is a most powerful session of the conference. Preventive cardiology, that's our main theme, and innovation in preventive cardiology is the addition to this theme. And we have the real legends of preventive cardiology right here. Especially Dr. Manchanda is here, and I'm sure there'll be some questions. Rick, you wanted to ask something?
Yes, I have a question for Dr. Manchanda. Of course, everyone knows the work of Dean Ornish and how groundbreaking that has been, but our own Dr. Manchanda went beyond what Dean Ornish did, and I'm wondering if you could please explain a little bit how it is that your work has gone beyond what Dean Ornish brought in.
You see, Dean Ornish encouraged us, but there were 3 limitations of Dean Ornish's work. One was that he used patients who had average 40% stenosis. As cardiologists, we said 40 to 35 is not clinically important. We wanted to do severe cases. Secondly, his program was not very practical. The vegetarian diet was given in the hotels. The patients were kept in the hotel. We made a user-friendly program which was possible in the home, and we used more than 70%. Dr. Gupta has also done more than 70%. So these are the limitations of Dean Ornish's study. Ours was more practical, and we used patients which were much more severe, which are of clinical importance. If you reduce 40 to 35, no clinical importance. But if you reduce 80 to 60%, it has some importance. Yeah.
Can I ask a question from Dr. Mishra from Dubai? Professor Mishra from Dubai, you presented a lot of myths. According to me, some of the myths are realities today, as of today. They are not myths. I mean, do you agree there? For example, he said that the prevalence of coronary artery disease is only in the males and it's not there relatively. And there was another thing which I felt.
Clarify.
Yes, there is indeed, as I said in the end, that some of the myths which has been proved over the epidemiological studies and in the lab has been taken as a part of the agreed statement. One of them is there is no difference in the sex except the little late in the females. So they have equal burden of the disease. Second one is the role of yoga, exercise and meditation has been accepted, which was 10 years before the people were doubting.
I think it's a very, very important point raised by Dr. G.S. Senani. And a lot of things have been said by Mishra. And I had a almost 20 minutes to 25 minutes dialogue with Lawson yesterday over the TV. And it has gone, the news has gone all over the world. And we really want to reach to a consensus, especially in reference to the role of vitamin D. I'm sure we have a session on vitamin D. And we also mentioned about the antioxidants as well as vitamin E. There are controversies everywhere. And there are controversies everywhere. And then there are controversies. And then we come to a consensus. I think just believing in 1, 2, or 10 or 15 randomized double-blind control studies and meta-analysis, I think we must individualize our patient. There is a role. There is no doubt about it. When we say that the vitamin D deficient people are more prone to get CVD or stroke or hypertension, that means there is something somewhere which we need to explore. That's what I feel. I'd like to have the opinion of Lawson on this.
Well, let me start out by, I'm going to do a lot of this in the talk, but there's general resistance to nutritional therapy in the scientific journals. There was a study published in New England Journal, amazingly, many years ago, looking at smokers in Scandinavia who took vitamin E, whether it decreased their chance of getting cancer. Well, they were given 5 units of vitamin E, and it didn't have an impact, and they declared that vitamin E is no good for smoking and lung cancer. But of course, the normal dose is 400 units of vitamin E. And I'm going to talk, if I get a chance, about a study by the Women's Health Initiative where they declared that vitamin D is not helpful, and I'll explain how the study was compromised from the beginning. And so, you know, it's definitely not a proven thing, but it's certainly a very attractive thing. And the basic problem is all these high-tech treatments, defibrillators and high-tech stents are driving the world broke, okay? And we need some simpler ideas. We've had a lot of lectures about lifestyle management. You know, I give patients advice on lifestyle management every day. My success rate is less than 10%. So again, we need to go back to find things that are simple that we can do and pursue them. How long did it take for yoga to be accepted as an effective treatment for cardiovascular disease? Can anyone tell me? Okay, so, and I'm going to talk about the history of the treatment of scurvy throughout the United States. Thank you.
I think it's a very, very important point. I will just have one more comment. And I think I'll ask both Mahala, please come here, and V. N. Mishra. I think Mahala brought a very important point that there is a role of omega-3 fatty acid as a secondary preventive method after bypass. And I'm sure some people, they believe it may also be a preventive method as a primary prevention. And yesterday again, we had a dialogue for almost 15 minutes with Lawson, and it was recorded on the television yesterday. It has gone all over the world. What is the consensus today? We'd like to have your opinion first, Vian.
Sure. Yes, regarding the vitamin D and this thing, there is no doubt, there is at least more than 20 studies they have shown the association. But because the confirmed after supplementation has not shown the same magnitude of effect, apart from bone, yes, it works in the bone, it works in the joint, there's no doubt it. It works in acute illness, there's no doubt it. General health being, no doubt about it. When we are talking particularly cardiovascular, MI and stroke, the answer is still not there. And that's why they designed Vital Study. Vital Study, everybody knows, is going on and it's going to give us the answer.
Mala, you'd like to give some comment on omega-3 fatty acid? There was a conference recently in San Diego, one-day meeting, only on omega-3, and the optimization of ratio of omega-3 and 6 and 9, huge data. It's anti-proliferative, anti-inflammatory. We'd like to have your comments on this because you showed in one of your slides.
I just wanted to ask all of you sitting here, how many of us has the vitamin D examination in the outpatient basis and found it is within the range? I'll tell you, more than 95% of our patient population are having very, very low. It's not insufficient, it's in the deficient range, less than 10. And the second point is we are prescribing them high dose of statin. And remember, it is atorvastatin calcium, the salt. And the patient population complaining of muscle cramps, not myopathy, is in the tune of more than 10% in Indian population. So if you supplement them D, and that's why all the companies has come with 1000 IUD along with the statin. If you find them, you give them D, 1000 units per day even, this is a low dose. You see within 2 weeks, their cramp is gone. And they are feeling very good. 2, about the vitamins, if you assess their B12 or the folate level in their blood, are they normal in our population? I am not sure. So we read the guideline in the context of outside India or the population who are nutritionally rich. The second point is if you give them a vitamin, I have not seen a patient, of course this is unpublished data, this is a practice, this is a type E evidence you can say, but they feel well with the vitamin supplementation. So are we lacking in the nutrition or are we having a clear-cut nutrition? So I think that answers our question. It should be absolutely individualized nutrition prescription like a drug.
I think I agree with Mahala. We are very poor in prescribing nutrition. We need to have a nutrition academy in India. They have in ACC. They do a conference on nutrition. We need to expand the knowledge of nutrition is very, very important. Whatever we do in our body, any amines, whether it's a catecholamine, or it is steroids, or it is DHEA, or it is serotonin, everything is made up of food. Everything is made up of food. Everything is made up of nutrition. And whatever medicines they act, they also act through chemicals. Either we increase the chemicals if they are reduced, or we reduce the chemicals if they are increased. So fundamental is very simple. We have to optimize. We cannot leave a patient, a vitamin D deficient, as deficient. And we cannot leave a patient of vitamin E insufficient as insufficient. We have to optimize the levels so that the inner biochemistry or neurohormonal chemistry is maintained.
Okay.
Otherwise, how can we have the actions? Nothing will act. Just now Mahala mentioned that the statins act better because vitamin D is given. Very right. So I think we need to do more studies and we should not believe straight away in one data.
Okay, I'm sorry
Keep
for
it
the
open of the controversy. I think this is very, very important session and we have to consider, and the last one is going to talk because he was very forceful and very authoritative in the statement yesterday, which he gave yesterday, so I'm sure he will going to give us a talk. Just a last question. Yes, last.
See, my question is about fruits and vegetables.
Little loudly.
My question is about fruits and vegetables. See, we have read in journals that 5 to 10 servings of fruits and vegetables per day is recommended. If I am correct, I have seen today Dr. Mishra's slide also shows the same thing, 5 to 10 servings of fruits and vegetables per day.
Yeah.
I want to know whether it is practical. When we advise this to our patient, they say that our stomach is full of only fruits and vegetables and we don't have a place to eat other things. How much is the practicability and what is the practical way?
Yeah, I think we won't waste much time on this because we have other sessions to go. But there is a huge data in 52 countries of inter-heart data published in 2004. And Mahala just mentioned 4 to 5 servings. You say practical or not practical, it's your choice. You have to make it practical. If you want to survive peacefully, comfortably, here is the data. Here is an evidence. We have to make it practical. Everything is possible. We need to change our perception and change our thought process. I think that's how we'll stop.
Okay,
I convey my best.
Mr. Chairman.
And just last, I think we have no time.
Opinion
So I'm
of
very
the-
extremely thankful to all the
Dr.
speakers
Mishra.
for doing a wonderful job. A last comment by Naveen because he told me that he wanted to say something.
I just had a very quick comment here. Number one, as Dr. Kantananda always tells me, there's no point in taking vitamin D and calcium unless you have a full stomach, unless your stomach is full and you have some fat in your diet. Otherwise, they don't get absorbed. So that's very, very important. Most of the physicians forget to tell this to their patients. The other comment I have is about Dr. Manchanda. He mentioned under the broad spectrum of yoga many, many things. Do you think you should add laughter there?
Laughter is a part of yoga. You see, the two things which we say in yoga is always remain smiling. 1 hour session we take, the first thing we tell, remain smiling. Secondly, do not exceed your capability. Some people at elderly age, when they do yoga, they try to bend too much, they break their spine. So these are two things. Do according to your capacity and remain smiling all the time. There's a gentleman who reminds them. And we have a laughter yoga program every 15 days or so, in which complete laughter is done.
Okay, thank you.
I agree with Dr. Manchanda. I must give you a very simplified mantra of a laughter. Laughter is an experience of divinity. Laughter is a tranquilizer like Campos or Alprex. Laughter is equalizer. Laughter is equipoiser. And laughter is happinessizer. What else you want? No medicine. All the chemicals liberated are enhancing serotonin levels, enhancing divinity. What is the problem? Dr. Manchanda said very clearly, a baby laughs 400 times a day to make you laugh, and an adult not even 4 times a day. Pathetic, very pathetic. And all the benefits are known to you.
Thank you very much.
Last comment.
Mr. Chairman.
I just wanted to add, sir. The animal that knows to laugh is called human. The human who doesn't laugh is an animal.
Yes, I just wanted to thank Dr. Mahala. I'm glad to hear that Narayana screens for depression.
The Brahma Kumaris know how to put smiles on everybody's faces. They gave bundi to everybody, all the speakers here, you know.
Yes.
I was congratulating Narayana for screening for depression. Depression and anxiety affect 2/3 of all cardiology patients at some point in the disease continuum. These are the very people who will refuse to engage in lifestyle change, who will continue to smoke, who will continue to do everything that's damaging to cardiac health. They should be screened. We have great tools to do it in minutes. Patient self-screens can be scored by a non-clinician in moments. And bam, you've got it. And you need to.
Okay. I think it's very important what Riza just mentioning, that we need to have a score, a so-called risk scoring, and people are in anxious state or in depression, and there is a huge correlation between the event rate after CABG or PCI of depression and anxiety. We totally agree with what she's saying. She said we need to create better scoring. Ultimate objective is to reduce the morbidity and mortality. Ma'am, your question and comment is excellent. We close the session now, and I'll request all the speakers, Dr. Manchanda, to kindly come in front of the desk. Dr. G.S. Senani, I'll request Naveen to join me here. Surendra Supu Rao, V.K. Mishra, and Dr. Mahala. For a little token of appreciation, Satish, please join me here.
Yeah. Brief presentation ceremony in
Poonam,
honor of our speakers.
please join me here. मिठाई खा लेना ग्लूकोज थोड़ा कम हो गया come Naveen
Naveen come and sweet are poison. You are giving us mithai.
Give it to Dr. Manchanda first. Dr. G.S. Senani, he is feeling very hungry, please. Dr. Surendra.
Very good, very good talk. So many things we didn't know about esophagitis, you know.
No, he's not here. Next one. Dr. V.K. Mishra. Dr. V.K. Mishra's talk was very provoking. Mahala. Dr. Mahala.
Thank you very much, Chairperson.